Thank you very much. So sorry to disappoint you guys with me not being Michael. He wishes he could be here, but family obligations. So his charge was to talk about kind of compressive neuropathies. And we can stop wherever and talk about whatever you guys want to talk about. So ask questions and I'll let you know my 2 cents on these things. And sort of, you know, my approach to all of these problems is to sort of rule out other things that it's not first. If I think it's a compressive neuropathy, I sort of look at everything else first to kind of get a lay of the land and make sure I'm not missing something like vascular status and the muscle tendon units, and then radiographic things, and then lastly sort of check sensibility and muscle strength. So vascular status is pretty common thing that we fortunately are pretty aware of in hand surgery. You know, this dorsal perinicular tissue is probably the most reliable for assessing vascular status in fingers. We always, you know, I'm sure when you guys read our notes, it says less than 2-second capillary refill on like 99% of them. And that's because this pink color is supposed to return in about 2 seconds or less. And arterial insufficiencies when it's pale, venous congestions when it's blue or kind of dusky looking, and refills too quickly, like less than a second. And you can Doppler them, or you can do an Allen's test, which is compressing one or both of the either radial or ulnar arteries. And then, I'm sorry about this horribly grainy picture, but muscle tendon units, you guys obviously know normal cascade of the fingers, and sort of assessing that through range of motion of the wrist and allowing the tenodesis effect to do some of the diagnostic work for you, I think helps. And then nerve injuries and kind of gross weakness we kind of know about. The sensory exam is a little bit harder. I like the question, does this feel the same or different as either a different distribution or the contralateral side? I think that is probably the easiest question for patients to understand from a sensory standpoint, just questioning them. And provides probably the most meaningful results, at least in my mind. If they say it feels different, I think there's a pretty high likelihood that there's something going on with the nerve. And then, of course, you know, more complex testing like 2-point and Sims-Weinstein monofilament testing. You guys know sort of the sensory distributions of nerves of the hand. The other thing to constantly sort of watch out for is spinal nerve issues, cervical radiculopathies, and be aware of where each of the nerve distributions for these spine problems are. And almost every patient I see in clinic who has some sort of numbness or tingling in their hand, I ask them, do you have any neck pain? And I think having neck pain is a pretty good marker of having potentially having some sort of spine issue going on. For compressive neuropathies, we think that chronic nerve compression causes a breakdown in the blood-nerve barrier, which is a continuation of like the blood-brain barrier. This edema causes increased pressure, causes perineural thickening of both the elements of the nerve itself and of the tissues around the nerve, and causes ischemia. And this can be particularly in carpal tunnel and cubital tunnel syndrome dynamic, like with prolonged elbow flexion or wrist flexion while people are sleeping underneath their pillows, eventually resulting in localized demyelination, or the normal conductive substance of the nerves degrading. And then finally, after the myelin sort of degrades and the compression is bad enough and the ischemia is bad enough, the axons, or the actual part that conducts signal, starts to degrade. And those sort of have two kind of distinct findings on EMG and nerve conduction studies. The myelin speeds nerve conduction, so initially you see slowing of the nerve conduction, and then as the axons start to degrade, you actually see the amplitude of the nerve signal go down. So it's getting less signal to the muscle as it goes on. Risk factors, seems like all of my patients, if Mike was given this talk, I don't know what he would be talking about, because he just sees 20-year-old healthy people, but people with diabetes, hypothyroidism, obesity, alcoholism, and in the upper extremity, interestingly, the ulnar nerve may be the most commonly affected to some extent, even though it's not the most commonly decompressed. There is this idea of a double crush phenomenon where, which is sort of controversial because it's also something that chiropractors use maybe to sort of justify doing chiropractic manipulations on people with peripheral nerve compression. But it's also to some extent a real thing. People who have compression at one level are certainly predisposed to it at another level. And so there is this idea that compression of the nerve in the cervical spine and compression of the nerve somewhere peripherally can kind of potentiate each other and not be like additive, but instead have a higher effect than the two things together. So, it's possible that release of the nerve distally may decrease the symptoms from the proximal site of compression, and also possible sort of in the other direction. And so we do sort of think about this, and I try to contemplate these issues because it's not an uncommon scenario where you see people with cervical radiculopathy and peripheral nerve issues, and deciding on the timing of peripheral nerve decompression versus cervical spine decompression is kind of something I think about a lot. And I largely defer to the spine colleagues, to my spine colleagues, to sort of tell me when they want me to do it, because while peripheral nerve decompression is a lot easier, putting people to sleep with significant cervical cord compression can be problematic, and the hypotension and that sort of thing associated with significant with anesthesia can cause ischemia to the spinal cord, which could be a big problem if it's at that point. So I let the spine people kind of tell me whether they want me to go first or they want to do their part first. So there's two types of touch, or large categories of touch receptors. There's the slowly adapting ones like Merkel cells and Ruffini end organs, and the quickly adapting ones like Meissner corpuscles or Pacinian corpuscles. And each of them is affected differently and and their axons are different, so they respond differently to nerve compression. There's also two types of discrimination that you guys probably know better than I do. There's threshold testing that requires the minimum amount of stimulus to elicit a response, and that's what Sims-Weinstein tests. And and then there's tactile discrimination, which is measured with 2-point and represents innervation density. And when you start to get axonal degeneration is when you start to lose 2-point discrimination. So we think that for compressive neuropathies, Sims-Weinstein monofilament testing is the best option. You guys know what Sims-Weinstein monofilaments are. Small nylon wires, very similar to fishing line. And you push the wire until it barely bends. The smallest monofilament that the patient can feel is recorded in each location. So we don't have to go in depth into these EMG and nerve conduction study things, but I don't know, it might be useful to kind of like think about it for a second if you guys are interested. So there's like 3 things that the electrophysiologists look at. There's amplitude of the signal, how powerful the impulse of the nerve is, how long that impulse lasts, and then how long it takes from the impulse to get for the impulse to get from one spot to another. And so they get shocked at this cathode spot, and then they record either the muscle, like here the thenar muscle is APB, or here they record the nerve impulses in the finger and the digital nerves to the index finger response. And so in carpal tunnel syndrome, for example, the first thing to be affected is likely some sensory changes, but they're less specific. So you don't have a diagnosis alone with simply just sensory changes. And once you start to get a lower amplitude of the muscle stimulation, that means you're starting to get axonal degeneration or severe carpal tunnel syndrome. So once you get to the stage of having axonal degeneration or severe carpal tunnel syndrome, it's really hard to get that muscle back. And so we try to get to people before they get to this sort of severe stage, because people recover better when they're in the mild to moderate sort of categories. And there's when you stimulate proximal and record proximal to the lesion here, you get slowing. When you stimulate proximal and record distal to the lesion, you get decreased amplitude of the signal. And when you stimulate proximal and stimulate distal and record distal to the lesion, then you really get the sort of the same signal, maybe a little bit slower because of Wallerian degeneration. And this sort of shows the same thing. EMG is where they actually stick the little needles in the muscles, and you can get fibrillations, or what we call positive sharp waves, which are a sign of denervation of the muscle and a sign of severe carpal tunnel syndrome. And these are the common upper extremity nerves that are tested. EMGs are pretty good for carpal tunnel syndrome. They're okay for cubital tunnel syndrome, but they really are not stellar for radiculopathies like cervical spine issues. So an MRI of the cervical spine is really the diagnostic test of choice for cervical radiculopathies, because on average, it's about 70% sensitive. EMGs are for radiculopathies. They're just not made to test that. So carpal tunnel syndrome, more common in men than women. There are a lot of these surgeries done every year, almost 500,000 decompressions per year. And kind of deciding on whether or not to get an EMG prior to surgery is a good question. Some surgeons don't, and I think that's totally reasonable in people with very classic symptoms who are sort of normal and have a high likelihood of getting better afterwards. But in workers' comp patients and other patients who maybe have either secondary gain or just not the sort of resiliency to improve after surgery, I think getting an EMG and nerve conduction studies before surgery helps give you some sort of baseline upon which to compare your after surgery results. And so I end up getting it in a large proportion of my people. But if they have classic symptoms, and especially if they've had an injection in their carpal tunnel in the past and it's worked really well, I think you don't have to get it. Injections, as we'll talk about in a second, are a very good predictor of how well surgery is going to work. You guys know the anatomy of the carpal tunnel. The median nerve runs through it, along with 4 finger flexors and your FPL. And just distal to the carpal tunnel is this superficial palmar arch, and the recurrent motor branch, it comes off. It's the first branch off the carpal tunnel here on the radial side. It can come through the ligament. It can actually branch off proximal ligament and kind of run superior or volar to the ligament, and it innervates the thenar muscles. Transverse carpal ligament is obviously the constrictive structure in this problem. It attaches to the scaphoid and the trapezium on the radial side and the hook of the hamate, pisiform ulnarly. It's what we cut, and carpal tunnel surgery is like the simplest thing in the world. You cut this transverse carpal ligament, and then that's it. The history is pretty classic. It's pain at night, and then numbness and tingling in their thumb, index, long finger, and the radial half of their ring finger. I like to ask the question to these people, do you wake up at night and have to shake out your hand because it's going to sleep? And I think that's an extraordinarily sensitive question for this problem. If they say yes, I think the chance of them having carpal tunnel syndrome is like 90%. Look for thenar wasting, because that is a telltale sign. These pictures are just horrible, but you can see nice bulk of the thenar musculature on the contralateral side, and then this sort of wasting of the thenar muscle on the right. Irritation with Tinel sign, sure, maybe that's a thing, but there is this idea that there's that neuritis or irritation of the nerve is not the same thing as compression of the nerve. So I don't know that a Snell's sign in and of itself is diagnostic of carpal tunnel syndrome or of cubital tunnel syndrome for that matter. 2-point discrimination is important in ruling out cervical spine issues. Usually exam and history is sort of enough to do that. The provocative maneuvers like Phelan's and Durkin's test have been shown to be the most sensitive and specific for this problem. And then what do you do about it? Activity modification, like for example, not flexing their wrist so much while they're sleeping. Wearing a splint at night is, I sort of make everyone with mild carpal tunnel syndrome do that, and I try to convince people with moderate carpal tunnel syndrome to at least try a splint. And then corticosteroid injection. So corticosteroid injection definitely helps. It helps in 2 ways. It kind of helps from a diagnostic standpoint, because if you have a corticosteroid injection, you have a good response. Your chance of having a good response to surgery is really high. And also it can, I was trained in a way, or in a place where, by surgeons who sort of thought that corticosteroid injection never cured people, and everyone who had a corticosteroid injection had to go on to surgery. And I think the literature doesn't really support that. 10 to 15% of people who have a steroid injection into their wrist go on to never need surgery on their carpal tunnel. Especially mild to moderate disease without any changes of the muscle, I think that's a reasonable thing to at least try. And then surgical decompression. This is one of the papers that compares, that looks at how many people who had a steroid injection ended up with carpal tunnel syndrome. 41% had surgery by the next year. The rest had an average of at least 2 more injections, and about 10% ended up with no surgery ever. This paper from JAMA compared splinting and surgery, randomized people to either splinting or surgery. Over the short and long term, regardless of whether it's mild, moderate, or severe, the surgery success rates were higher than splinting alone. And even in this randomized controlled trial, about 40% of the people who were randomized to the splinting group ended up with surgery eventually within 2 years. So the chances, while a brace is a reasonable thing to try and you should try it, surgery is probably a better solution in the long term. And then surgical decompression, like I was saying, it's really relatively straightforward. Hopefully nobody's making an incision like this, but you make a small incision that divides the transverse carpal ligament along its ulnar aspect to stay as far away as possible from the thenar motor branch that innervates the thenar muscles. And that's the deal. It's fairly straightforward. There's, like we talked about earlier, people with severe carpal tunnel syndrome improve, but not as well, but not as much as the people with moderate to mild disease. And this study sort of shows the same thing. Those people with severe disease do less well than the people with mild to moderate disease, because there's some sort of intrinsic damage to the nerve from long-standing compression. We can fix compression, and I have this discussion with patients who get sent to me from other people, like after their surgeries all the time. We can fix the compression around nerves, but we just can't fix the intrinsic damage to the nerve. If there's long-standing damage from long-standing ischemia to the nerve, there's no surgery, unfortunately, at this stage in the game that's going to fix that. We can decompress it. Sometimes that helps, but you can definitely do more harm than good by decompressing a nerve too many times with the hopes of recovery, and I'm sure you guys have all seen that. The open carpal tunnel release has a long history of effectiveness. 95% of people are happy after it's all said and done. Has relatively low complication rates. It's easy and simple, and it's been around for 40 or 50 years. And the endoscopic method is newer, but still 20 years old probably. John Seiler actually wrote one of the seminal papers on this thing, back in the 80s. And it's a smaller incision which is centered off of the palm, but in the volar wrist crease, and maybe decreases a little bit of the pillar pain and incisional pain there, but people still definitely get pillar pain after this. And makes a smaller incision, and maybe there's slightly less wound healing issues. But at the same time, there's a real learning curve for this thing. Here you go, Seiler's paper. There were more complications in the endoscopic group, four complications out of the a couple thousand they did. The cost is a little bit greater, but there's less scar tenderness, better pinch strength, better return to work for endoscopic, or faster return to work for endoscopic. But definitively no difference in the relief of symptoms. Sensory testing, they seem to have the same outcomes, maybe just get better a little bit faster. AG is actually a guy who invented this thing, and I think still makes royalties on it to this day. And he found that they returned to work about 3 weeks earlier, 21 days sooner on average. There's less scar tenderness and pillar pain, greater grip strength, but it's not significant by the time you get to about 3 months. But even he, the guy who invented this and has arguably done more than everyone else, had an incomplete release and 2 transient ulnar neuropraxias. And then they did a prospective randomized trial on the same problem and sort of found all the same stuff. Endoscopic had a higher rate, or had transient ulnar paresthesia and an incomplete release, which was the 3.7% complication rate. But the open had a higher wound infection rate, higher rate of scar tethering, and scar hypertrophy, which was a slightly higher number. Arguably, incomplete release is possible, but ulnar paresthesias are not something that should normally happen after endoscopic carpal tunnels, because you're really nowhere near the ulnar nerve, or at least you shouldn't be. So despite seeing this in all the papers, I'm slightly concerned that either they're having the residents or fellows at their institution do this where they're not doing it a lot and they're getting this thing next to the ulnar nerve instead of in the carpal tunnel itself, because as you guys know, the ulnar nerve does not run in the carpal tunnel, or something weird's going on causing ulnar paresthesia. Just doesn't make much sense. And so I give people the option to do either one. I think endoscopic is very reasonable for people who want to get back to work sooner, and I do think it has a lower wound healing rate, or a lower wound complication rate, but there are totally benefits to open, and I do opens as well, and they do equally well when it's all said and done, but it maybe just takes a little bit longer to get better. So I think there was early on in the experience a higher risk of neurovascular problems, and I certainly don't think like sort of the average generalist orthopedic surgeon should be doing it endovascularly, or endoscopically, but yeah.
Well, I noticed on your study that you cited splint versus surgery.
Yeah.
That there were no hand therapists on the study, and it just said splint, which of course I don't know about anybody else in the room, but I don't think any of us know exactly. We know a person's had surgery when they've had surgery.
Right.
But you don't know what kind of compliance you've gotten with the splint.
Valid.
The patient comes in and says, "Oh yeah, doc, I've been wearing this every night." I have a hard time believing that. And
Yeah.
did they get any activity modification? Did they change their work at all?
Right.
Because they were just wearing a splint all, and they're continuing to, make solder, silver, jewelry for, 40 hours a week.
Right.
No, they're not going to get better. So
Yeah.
That study I find a little shaky.
Right.
Because I don't think you really explore the non-surgical options. I don't think you're really totally comparing non-surgical and surgical option,
I agree. Yeah.
Education.
Do you guys have good success treating people with carpal tunnel syndrome non-operatively? Like, are people happy?
I think you have to spend some time. You have to spend time educating them.
Uh-huh.
You have to explain to them what it is. You have to teach them the anatomy, and then you have to explain to them why they're having those symptoms. And you have to explore a little bit their work, their ADLs, their hobbies.
Uh-huh.
So, I usually do it maybe in one session, and then tell them, where to explain.
Do you guys find that work and things people do contribute to their carpal tunnel symptoms? Really? Okay.
Dramatically.
Interesting. the teaching in the hand surgery world these days is that there are very few activities that we think contribute to carpal tunnel syndrome, and I don't know where the right answer is. You know, people come in with workers' comp injuries and it's carpal tunnel syndrome, and we just haven't found the happy medium for what the right answer for whether this is something caused by their diabetes and their thyroid problems, or something that they were just going to get anyways because it's sort of, you're just predisposed to it from birth, or whether it's a work-related injury. And I mean, I think the current recommendations from the American Society for Surgery of the Hand are that there's no work-related issue that would predispose you to carpal tunnel syndrome except for high-impact vibratory activities like using a jackhammer. And so I don't know where where we're going to eventually end up on this answer, but it'd be really interesting, and it's something we should figure out, because every patient comes to me saying, I type all the time, I use all the ergonomic things, and it's this typing that's causing my carpal tunnel syndrome. And I'm like, I don't know, maybe, you know, it's not worth I don't know, maybe changing how you rest your hands on the keyboard helps, but maybe you're just sort of predisposed to this thing, and I don't know the right answer.
Well, I think one thing that's really important is when your patient tells you they have carpal tunnel, you know, particularly, you know, somebody who wants to get something out of it, they know people with carpal tunnel, and they've got a lot, they have looked it up on the internet, and they answer all the questions just right. So
Right.
Say, are your hands numb at night? Oh,
Right.
You know, so I would be careful in making, to me,
That's true too.
decision based on just verbal, because
Yeah,
they have a lot of information.
right. Yeah, it's a complicated topic for sure. All right, that's interesting. Cool. So there are other causes of median nerve or nerves distal to the median nerve compression that are very rare. And if you see people diagnosing these a lot, I've seen 1 or 2 cases of this stuff ever. So compression of the median nerve in the forearm resulting in purely sensory issues we call pronator syndrome. And then compression of the AIN resulting in purely weakness we call AIN syndrome. Often pronator teres is the culprit. You get numbness in pronator syndrome, you have numbness, tingling in the sensory distribution of the median nerve, including the palmar cutaneous branch, like the palm. Resisted forearm pronation, resisted elbow flexion, resisted forearm supination, resisted flexion of the long finger, flexor digitorum superficialis, and pain with pressure over the pronator teres with forearm in maximal supination are signs that this thing's going on. And then anterior interosseous syndrome also is pretty rare, less than 1%, and I'd argue way less than 1% of peripheral neuropathies, and it causes weakness in FPL, maybe sometimes FDP to the index, but the characteristic thing is this pinch deformity with extension of the IP joint of the thumb when they're trying to pinch. It's pretty common, and it's the common finding, I guess, and it's a good reason in everybody who has carpal tunnel syndrome. I test their FPL strength in all of them to make sure I'm not missing some weird thing. What do you do? There are some sites of compression of this nerve that we know of. There's this thing called a supracondylar process, which is a little bit of a prominence off of the medial aspect of the humerus. There's a ligament of Struthers that runs from that supracondylar process to the medial epicondyle. The bicipital aponeurosis can compress it, the deep head of pronator, or this fibrous arch, which is kind of like the start of FDS. It's unfortunately not pictured. Oh, here it is, sort of divided, but it lays right over here. Yeah. And then cubital tunnel syndrome. It's the second most common peripheral nerve compression that we decompress surgically, at least. It's in this groove between, as you guys know, the olecranon and the medial epicondyle. The night symptoms like sleepy position with their elbows flexed or now cell phone use and other athletic activities can make it worse. We get these people get numbness and tingling in their small and ring fingers, and pain at night, wakes them from sleeping. Worse with elbow flexion or pressure on the medial elbow. They get numbness and tingling in the ulnar nerve distribution and irritation with Tinel's. You can palpate the ulnar nerve in the retrocondylar groove through range of motion and see if it subluxes. You look for interosseous wasting, and you can sort of see that here, this significant wasting between of the first dorsal interosseous muscle here. Rule out cervical spine disease. Obviously, EMG and nerve conduction studies can be useful, but they're not as good in cubital tunnel syndrome as they are in carpal tunnel syndrome. So they don't pick up all cubital tunnel syndrome. So there's kind of currently a lot of back and forth over what the best diagnostic modality for diagnosing cubital tunnel syndrome is. And I think EMG and nerve conduction study is a good first test. But we're thinking, and we're actually in the process of investigating, what should be sort of the second best test, or what is most likely to predict those patients who do better after surgery for cubital tunnel syndrome. And we're currently thinking that ultrasound, being able to measure the nerve proximally and distally to the cubital tunnel and the amount of swelling of the ulnar nerve just proximally cubital tunnel, what we call the maximal cross-sectional area, is most predictive of cubital tunnel syndrome in patients with negative EMG and nerve conduction studies. People have tried to inject the cubital tunnel like with steroids, similar to how we do for carpal tunnel syndrome, and the jury's certainly still out on that, but the most, at least my opinion, and kind of like the most recent data seems to suggest that it doesn't really work or do a lot. What else? On exam, bend elbow past 120 degrees and hold it for a minute. That's this passive elbow flexion test. Again, a Tinel's over the ulnar nerve at the elbow is maybe a sign of neuritis, but I don't think neuritis is the same thing as compression of the nerve. It's irritation of the nerve. Certainly neuritis can happen from compression, but neuritis can also happen from a number of other things that may or may not respond to decompression. So you guys know about Frohman's sign, a weak adductor pollicis. So thumb MP and IP flexion compensates for a weak adduction of the thumb. And Wartenberg's sign, where the small finger abducts out to the side. This unopposed EDQ, eccentrodigitoquintile, that has some innervation from a posterior interosseous nerve and inserts on the ulnar side of the finger. Intrinsic atrophy, we sort of talked about that. You can see that here. And clawing, you know, the classic ulnar claw hand with severe ulnar nerve involvement from a lack of intrinsic function. And so what to do about this cubital tunnel syndrome thing? You know, I think we have reasonably good success with braces in a lot of people. I mean, I seem to get cubital tunnel syndrome 30% of the time, and if I just straighten my elbow a little bit when I sleep, I get better. I don't know, what are your thoughts on braces? They seem, you guys have reasonable success with either braces or this other trick, wrapping a pillow around or a towel or what have you around the elbow, and just to kind of give them some sort of gentle reminder to keep their elbow a little bit straighter at night. 50% of cases will improve spontaneously. We do think a certain number of people, particularly younger people, just get this cubital tunnel syndrome and it sort of gets better, and we don't really understand why. Maybe it's a little bit of inflammation of the tissues around the medial elbow that cause a little bit of extra compression or a little bit of neuritis of the nerve that makes it a little bit more sensitive to compression and elbow flexion. And we're just not exactly sure what causes it, but about half the cases get better on their own with just splinting them a little bit straighter at night. And then surgical decompression. So, you know, while splinting them at night is a great thing, once they start to get this atrophy and weakness of the intrinsic muscles of their hand, you can sort of live without the thenar muscles of your hand and sort of have a reasonable existence. But the intrinsic muscles of your hand are a game changer when they don't work anymore. And so I think the ulnar nerve at the elbow is a little bit higher stakes. and also in the fact that it's a lot higher up, and so the recovery time's a lot slower to get nerve function back to your hand. It doesn't regenerate as well, and certainly after decompression, people after carpal tunnel release are pretty happy pretty quickly, and their sensation recovers reasonably well, but that's definitely not the case in cubital tunnel syndrome. They take longer to recover. They never get 100% recovery. It's a little bit more prolonged sort of process for sure. In situ decompression is sort of the gold standard at this point. We used to think that you had to move this nerve out of its groove 10 or 20 years ago, and there have been good recent studies, maybe not even that recent anymore, that showed that in situ release, just releasing this nerve, releasing the tight bands of fascia overlying it, and then leaving it is fine, and has equivalent results, and is less surgery, less morbidity, all that sort of thing. In the revision setting, like when you're redoing this for whatever reason, or if there's hardware in place, or arguably if there's subluxation of the ulnar nerve, subcutaneous or intramuscular or submuscular transposition is a reasonable option. You can also do this thing called a medial epicondylectomy that some people do, taking a little chunk off the medial epicondyle, kind of separate from the flexor pronator mass and where the ulnar collateral ligament attaches. And maybe in that way sort of shortens the distance that the ulnar nerve has to travel a little bit and kind of smooths out the backside of the medial epicondyle a little bit. I don't do that, but some people do, and it's not completely out there. The band of the deep brachial fascia, this arcade of Struthers is this band of deep brachial fascia that's about 8 centimeters proximal to the medial epicondyle. The medial intermuscular septum can be a site of compression between the flexors and the extensors of the elbow. Osborn's ligament is the tissue directly over the cubital tunnel, and then the flexor carpi ulnaris fascia can also be sort of tight here distally. In situ decompression, certainly my go-to move for people who have never had their ulnar nerve operated on in the past, who don't have any hardware in there, and who don't have subluxation of the ulnar nerve. It's pretty straightforward and pretty easy. You just release up and down along the ulnar nerve, and very similar to the carpal tunnel, you're sort of done. The medial epicondylectomy, you take off this little chunk of bone posteriorly. Anterior subcutaneous transposition is where you sort of divide, create a layer between the muscle and the skin, and lay this nerve on top of the muscle. And usually as you move the elbow back and forth, it sort of wants to go back into its groove. So typically we have to take a little strip of fascia of some kind and attach it to the subcutaneous fat and to kind of hold it in place anteriorly. And this is that study in the Journal of Bone and Joint Surgery that sort of proved to everyone that in situ decompression was the same as transposition. Intramuscular transposition is where we make a hole in the muscle, or make it like a slot in the muscle for the ulnar nerve to sit in. Its proponents are a person in St. Louis at WashU who is a very big nerve surgeon and very smart, but and her argument is that it increases the vascularity around the nerve by putting it in the middle of this well-vascularized muscle. But I don't know that that's been proven, and people worry about scar around the nerve and that sort of thing. And then submuscular transposition is what most people would do for multiply revised nerves, and I think it's a totally reasonable thing and what I would do. But it requires detachment of the flexor pronator muscle mass. So you have to take the flexor pronator muscle mass off of the medial epicondyle, lift it up, put the nerve on the joint capsule, and then somehow reattach the flexor pronator muscle mass back down without causing more compression on the nerve. So we do a little step cut sort of thing. The flexor pronator muscle mass is actually sort of like a pretty resilient sort of structure, kind of like in lateral epicondylitis, where some surgeons sort of cut all of the extensor musculature off of the lateral epicondyle. You can also cut all of the flexor pronator muscles off of the medial epicondyle, and people have totally normal hand function. It scars back down and it's fine. We repair it back in an abundance of caution probably, but this is the nerve, the hands over here, the shoulders over here. This is the ulnar nerve, the medial epicondyle is right here, and you can see how in maximal elbow flexion this nerve sort of sits on the medial epicondyle. And so this person has had surgery in the past and didn't get better after it. So in people who have who've had surgery in the past and haven't gotten better, maybe as I touched on earlier, the messing around with the nerve too many times is just a recipe for disaster and like something bad to happen. So on the second time around, I'm going to do everything that I can do to never be operating on that nerve ever again. So I would do a submuscular nerve transposition because that is sort of like the end all be all. There's nothing more that you could ever do. And so we detach this flexor pronator muscle mass, and then we repair it back over top, and it kind of sits there in its shortened position, and people do pretty well. But it is a lot longer recovery and a lot bigger surgery than sort of an in situ decompression for sure. I talked about this last time, but in some people with severe motor wasting of their hands, this anterior interosseous nerve transfer is a reasonable thing to consider. The ulnar nerve also gets compressed in Guillen's canal. It's a pretty straightforward procedure, very similar to carpal tunnel release to release Guillen's canal at the wrist, and not a particularly big deal. There are 3 zones that it can get pinched from. A bunch of different things can cause it, like hook of the hamate fractures causing abundant callus around that area, pisiform issues, hypothenar hammer syndrome, where the ulnar artery gets an aneurysm inside of Guillen's canal and causes compression of the nerve. And it can just happen kind of idiopathically also. And there are like a million things we can talk about radial nerve entrapment syndromes, which are like exceedingly rare. But if you guys have any thoughts on cubital tunnel syndrome, I'd love to hear them. If you have any, like, do you feel like people are recovering after their cubital tunnel releases? Are you seeing a lot of problems with scar sensitivity? Like, are you having good success with splinting them and therapy? Anybody?
Depends on surgeon.
Right.
Very surgeon dependent.
What do you mean, like after surgery? Some patients just don't seem to get as much recovery as others. Are you guys seeing people doing endoscopic cubital tunnel releases at all? It's something that's described, and I think a bad idea because I think you can't decompress it enough that way. Huh, that's interesting. You know, I think patient selection is also like a really important part of this whole thing. It turns out that like cubital tunnel releases don't work on people without cubital tunnel syndrome, you know? And that's what I tell patients all the time. Like, you know, I get that your hand is numb, your whole hand's numb, but I promise that this surgery is not going to work on you if you don't have carpal tunnel syndrome and cubital tunnel syndrome. Getting that across takes a lot more time probably than releasing it does. So I think finding the right patients who have a problem that can be solved with surgery is part of the struggle.
You can tell pretty quick.
Yeah, you sure can.
For those people, they've got terrible thick scarring, and just every time they move, they're in pain.
Right.
And other people, you're just like, they get this nerve lights going, and they're happy.
Yeah. Yeah. What do we have left? We have 5 more minutes. You guys want to race through radial nerve entrapment syndromes or eat some pizza and leave? Okay. All right, so I don't know. I mean, high radial nerve palsies are common, but sort of like outside of the scope of this discussion. It's not really a nerve compression, that's just a nerve injury. Radial tunnel syndrome, the radial tunnel syndrome's kind of like we think maybe it plays, we're mistaking it, or we're mistaking lateral epicondylitis for it sometimes maybe. It's hard to diagnose, easier to treat once you diagnose it appropriately, but it's very similar to cubital tunnel syndrome. There are these a bunch of sites of compression that it could possibly be. We think maybe athletes and manual laborers are predisposed to it. This area of pain is about 5 centimeters distal and lateral to the epicondyle. The radial nerve, as you know, kind of spirals around the humerus up here and then goes anterior, just anterior to the radiocapitellar joint at the at the exact middle of the radiocapitellar joint, directly anteriorly, and then goes around the radial neck about 5 centimeters distal to the radiocapitellar joint, which is where it tends to get pinched right here. They say there's pain with resisted middle finger extension and pain with resisted supination or elbow extension. There should not be motor deficits from this problem. It's mainly a pain problem. And the argument for that is that these large efferent fibers, or the small afferent fibers, the nerve fibers that go back to the brain, are more sensitive to this compression than the larger motor fibers. And so how do you differentiate it from lateral epicondylitis? There's this tenderness directly over the lateral epicondyle. PIN syndrome is a different problem. That is the motor problem. And EMG and nerve conduction studies really don't show this well, which is also somewhat concerning in finding the right diagnosis and sort of like in my mind justifying that this is a real thing. And the treatment, NSAID, splinting, physical therapy, and after 4 to 6 months of being completely tortured by it, you could consider releasing it. It's the same as the PIN release. The outcomes of surgical treatment are sort of controversial. Again, getting back to like, are we treating a real thing that's really solvable with surgery? There are reasonable studies on it in people who looked at this, who kind of studied this a lot and maybe massaged the numbers a little bit. They did pretty well, but in other people who maybe weren't as good at selecting their patients, they did not do particularly well. So they're sort of all over the map on what the results are. So Torianos, who's actually a good, trustworthy person and would write it, sort of tell you like it is, and is it in Pittsburgh, studied this, 35 patients, which is a lot, and about 14%, subjectively a lot were excellent, like most people, maybe less than half, but a significant proportion thought they were excellent or good. And then according to this Rolls and Maudsley criteria, which is a criteria for radial tunnel syndrome, they were not as good. Posterior interosseous nerve compression, nerve syndrome is a similar thing, except it's the motor side. Lipomas and ganglions of the elbow and that sort of thing. Rheumatoid nodules or pannus can cause it. Elbow fracture dislocations can obviously cause it. Usually they don't have pain and just have weakness. And ECRL is usually preserved, so they usually have some wrist extension, but with radial deviation because ECRL is the only one working. And they can typically have decreased extension of their fingers and their thumb. You should get an X-ray. You should get an MRI to look for a mass because that's probably the most common cause of this is a lipoma directly adjacent to the posterior interosseous nerve. And nerve conduction studies are positive in this problem. You can try and treat it with splinting and physical therapy and stuff, but in my mind, those things with motor weakness are things that we should probably be thinking about addressing sooner rather than later. Particularly if there's like a real mass or something compressing the nerve that's only going to grow. So there are a bunch of different approaches for getting at this thing. I really like between brachioradialis and extensor carpi radialis longus. It's a nice plane. The nerve sits right there on the radial neck, and you can sort of see it and see whatever's compressing it and get it out. Wartenberg's, as you guys know, is at the level of the distal forearm, where the superficial branch of the radial nerve gets compressed between brachioradialis and the radius, or between brachioradialis and ECRL. It causes pain in the dorsum of the hand, and a bad Tendon is right over top. You can injure it from de Quervain's veins, releases potentially, or external compression like tight bracelets and that sort of thing, or it can be idiopathic, probably most commonly. Provocative tests like forearm hyperpronation and ulnar flexion of the wrist is what they say brings it on. You need to rule out de Quervain's veins, which is pain more distal, and with Finkelstein's test, rest, splinting, and NSAIDs are definitely the first line treatment. You can try and inject some steroids around that area, and then you can decompress it if it's still no better. So that's what I got. All right. Any questions? All right. Thank you guys very much.